All right, and we're recording. All right, introduction to pharmacology. All right, pharmacology, what is it? Well, it's just a study of the drugs or medications, and we use the term drug and medication as synonymously in this class. It means the same thing. A lot of people think that drug is something bad and it's something illicit, but drug and medication really mean the same thing. So you'll see drug and medication in the same context here. It's just a study of them, where they come from, the nature of them, and their properties. So it's a study of the interactions that occur between a living organism and the effects of the medication. It encompasses a lot of different things, and a lot of these things we're not going to be able to talk about in an incredible amount of depth, but I want to give you guys a good appreciation for some of this. Their composition, their interactions, toxicology, how we use them therapeutically, and then most importantly, their medical applications and antipathogenic. That's just a big word that means fights pathogens or fights disease-causing things. Okay, so basic terms. So we have the term therapeutics. It's the study of medications that are used to cure, treat, or prevent diseases. Then we have pharmacotherapy. It's just a study of the application of drug therapy to treat a disease. And then we have these two guys here. And how many here are at least 30, 35 years old? Oh boy. Okay. So you guys remember back in the day, I don't know if they do it, they really don't do it anymore, but back in the day when I was younger, this was a great thing to do. I was in Kmart. Remember Kmart was in its heyday. And you were walking around Kmart with your basket, and what would happen every so often? They put the blue light special on, right? The blue light. We've got a blue light special in aisle 5. Come and get them. If you guys aren't old enough to remember those wonderful days, I'm sorry. I can't reproduce them. But if you do remember, but the point of that is, sometimes I will say blue light special, and that's a key to you guys. Hey, possibly this might be on an exam. All right, so blue light special here, pharmacodynamics and pharmacokinetics. So dynamics is a study of the interaction of chemicals with biological receptors. Boy, that sounds really complicated, doesn't it? The way I look at pharmacodynamics is this. Pharmacodynamics is what a drug does to the body. Does that make it a little simpler, a little more intuitive? Pharmacokinetics studies the absorption, distribution, metabolism, and excretion of chemicals from the biological system. That sounds really complicated as well. Let's go ahead and distill that down. Pharmacokinetics is the study of what the body does to a medication. So dynamics, medication does something to the body, and kinetics is the body does something to a medication. And I always think of kinetics, what is kinesis? What does the word kinesis mean? Movement. Yeah, it means to move. Like kinesiology, for example, is a study of movement, generally with humans. So pharmacokinetics is literally the movement of medication. Okay, and we'll come back to those here in a little bit. Drug development, lots of different places drugs come from. Plants, animals, minerals, chemicals, recombinant DNA. And recombinant DNA has actually become very popular now. And basically what we do is we take DNA and we inject it generally into a bacteria, like E. coli. And the bacteria will then read that DNA and create the substances that we want. That's basically what happens with recombinant DNA technology. Blue light special here. The FDA, or the Food and Drug Administration, regulates drug testing and approves the release of new medications. So that's the main agency that we are concerned with, in the United States at least, as far as what medications are approved to do what. Okay, where do we find information on medications? This is going to be really important, certainly in clinical environment. Drug guides. You guys all seen the little nursing drug guides? They're all around, all over the place. They're pretty good. There's also something known as a PDR. It's a huge book. It's even bigger than this Egan's book here. It's called the PDR, the Physician Drug Reference. And basically, and we'll talk about these a little bit more, but have you guys ever opened a medication and out falls a piece of paper and you open it up and you go, oh, that's too complicated for me. That's written in Greek or something. That's called a drug insert. Basically what the PDR is a big collection of drug inserts. So pretty comprehensive information. There are different guides online, and Nobody here has a cell phone, right? And one of the new smart iPhone or Android or whatever. Nobody has those, right? Right. Probably most of you guys have some sort of smartphone. Yeah, who doesn't, right? Hopefully it's an iPhone. Hopefully. If it's an Android, just don't tell me you have one, and we'll be all right. But there are different guides that you can download. One of the most prolific ones is called Hippocrates. That's a really good guide. It's free, and it updates itself all the time. Android, iPhone, anybody using Palm OSs can get Hippocrates. Micromedics is very popular in the hospitals. It's an online system that they'll use. There are also different types of little what they call field guides, little flip guides that you can use. My question is there a possibility for bias in any of this information? What do you guys think? If the PDR is nothing but a bunch of inserts from the manufacturer of a medication, is there a potential for bias there? Yeah. Possibly. I'm not saying there is, but there is. Oh, that kind of didn't sound like it. I'm not saying that there is, but there is potential, we'll say. There is potential. So the ultimate guide or resource in the United States is considered the USP, or the United States Pharmacopoeia. And that is considered the ultimate, quote-unquote, bias-free drug guide that you have out there. But any of these will work reasonably well. Yes?
What do you mean exactly by, how would it be biased?
Well, let's say that a company that makes a package insert leaves out a couple of studies that have some negative information about their substance. Is there bias in leaving those out? Possibly. Something on the lines of that, where you don't have true objective information, or maybe not the whole story. Now, I'm not saying that happens consistently, but there's always the potential for things like that to occur. Drug information. Little blue light special here. Okay, we have different names for a drug. We have something called the chemical name, and that's a really long, complicated name generally. And it looks like the organic chemistry that you had to do, something like that. There's also something called a generic name and the brand name, and these are very important for us. These are the most important things for us. A generic name is assigned by the adopted names, or the USAN, and basically what happens is when a medication first hits the market, a certain company makes that medication, and no one else can make it, right? That company for so many years has exclusive rights to make that medication. Then what happens after so many years? Everybody can make it.
Patent goes on.
Yeah, the patent goes away and everybody can make it. Well, the company that makes a medication, when they manufacture, they manufacture medication under a brand or a trade name here. And an example of a brand name would be Tylenol, for example. Tylenol comes from a certain company. However, there are also other companies that just make the generic or non-branded name. It's the same medication, it's just that these other companies are making this medication after that trademark has basically expired. That's called the generic name. Is there really any difference in the chemical composition of the medication? No, there isn't. It's the same medication, but the difference is that a certain specific company is putting their brand, their trade name on that medication. How do we tell a trade or brand name from a generic name?
Capital letters.
There you go. That's the easiest, quickest way. Is the trade name will always be capitalized, and I'm going to go ahead and pass these around. And this is a little what's called a meter dose inhaler we'll talk about. It's called Vanseril. And you see the capital B, that is the trade name, but underneath it says beclomethasone, and you can see the little B is small case or lowercase, and that's a really quick, easy way of differentiating between a generic and a brand name. Generic lowercase, brand name uppercase. I'm also going to pass a little Advair around, and you can just read right underneath the Advair is the generic name of it in lowercase. And these are all medications that we'll be talking about. And then we have another medication called Proventil, with a capital P, and then albuterol with a lowercase a. So I don't know if anyone's ever noticed that before or not, but I think it's kind of neat. Now you can go home and look at your medications and go, wow. Okay, so good there.
Can I ask a quick question?
Yeah.
Is this on PowerPoints, or do we have to be writing this stuff down?
It is on PowerPoints.
Okay, nice, then, okay, thank you.
Yeah, no problem. And I sent that email out through your lab, because those are the only classes you guys have, so you should be able to see that pop up on your lab. Okay, clinical pharmacology, that's the mechanism of action, and we'll talk about that a little bit. And then indications and uses, and the FDA approves a medication for specific uses. You can use this medication for bronchospasm of the lungs. However, sometimes you will see a medication used for something that it's not approved. And you'll hear the term off-label. That's what they mean by off-label use, is you're using a medication for something that the FDA hasn't officially approved its use for. Now, is that wrong? Not necessarily. Not necessarily wrong, but it does kind of get into a gray area. But you will see this off-label use sometimes documented. Okay, contraindications. Well, these are warnings concerning particular patients or situations that the drug should not be used in. Contraindication doesn't definitively mean never use. A lot of times it means we need to be cautious when we use it. And there is actually something called an absolute contraindication. If you see the term absolute contraindication, that means you cannot use that medication, period. So if somebody has a certain condition, and it says if they have this condition, it's an absolute contraindication, we cannot use that medication. Everything else is what we call a relative contraindication, where you need to be very careful if you're going to use it for certain situations. And we'll talk about those when we get into the drug classes. Precautions, and then situations that may require close monitoring. Okay, interactions. There are lots of different interactions, and down here, the three guys I'm talking about, kind of a blue light special there, we have something called an additive interaction. And that is to say, if I give one medication and another medication, the combined effects will equal the combined effects of both medications. It's pretty intuitive, and basically the way I look at it is it's 1 + 1 = 2. So if I give a pain medication that has so much potency, and then I give another pain medication that has so much potency together, I add them together and I get whatever the added potency of those medications is. So nothing real special there. But then I get into something called synergism or synergy. And that is, if I give two drugs together, the end result is greater than the effect of either drug given by themselves. And the way that I like to look at this in my mind is 1 + 1 = 3. So let's say that I give a pain medication with a little bit of pain controlling ability, and then I give another pain medication with a little bit of pain controlling ability. So two medications with just a little bit, and all of a sudden the patient has massive pain control. They're able to control all their pain by giving them just these two medications that just do a little bit. That would be an example of synergism, that I'm getting this huge effect out of two medications where you wouldn't expect that effect to occur. And then there's called potentiation. Big blue light special here, you might see this later on. One of the drugs having no direct effect increases this response of another drug. And an example that I'll give you guys is a pain medication called morphine. And you don't really have to know its pharmacology at this point. It's a pain medication. Okay? And sometimes morphine can cause people to become nauseated, an upset stomach. So what I can do is I can give an anti-nausea medication called Phenergan. Okay, Phenergan does not control pain, has no pain control effects, okay? Morphine's pain controller, Phenergan's for nausea. What do you suppose happens when I add those together? The pain control effects increase substantially. So I'm giving a medication that doesn't control pain with a medication that does control pain, and I get massive increase in pain control. That is what potentiation is. I'm giving a medication that does something, and another medication that does something, but this medication doesn't do anything for pain. But when I give them together, I get an incredible amount of pain control that is not predicted by giving them by themselves. Does that make a little fairly intuitive amount of sense? And this is a very common type of situation they'll give you if you see this on exam, a pain medication and medication for nausea, and then they have increased pain control ability. Okay, adverse drug reactions, or what were called ADRs. These are unintended side effects to prescribed medication. Some side effects are mild. Some can be very severe, life-threatening. Some of the things that we run into as respiratory therapists are tremors, bronchospasm. Anyone know what bronchospasm is? Yeah. So you're good because you know some people may or may not know exactly. You have little muscles that wrap around your bronchi, your airways, what we call your intermediate airways, and if those muscles get kind of irritated or through chemical messaging, those muscles can get activated and they kind of constrict, like this, and close that airway down and decrease the diameter. That's what they mean by spasm, and we'll talk about why that happens. Allergies. There is a certain allergic reaction that's very severe. So you can have just an allergy. Maybe you get some hives, maybe you have some diarrhea. But if somebody has a severe allergy called anaphylaxis, you guys ever heard of that term, anaphylaxis or an anaphylactic reaction? That is a severe reaction that causes bronchospasm. It causes what's known as angioedema or severe swelling, airway compromise, hives, hypotension. The blood pressure gets really low, and we have to treat anaphylaxis with epinephrine. And we'll talk about why a little later on. But just know anaphylaxis is a very severe allergic reaction. It's the worst kind of allergic reaction you can get, and it causes all these things, and we have to treat it with a medication called epinephrine. Okay. So if somebody says they're allergic to a medication, we need to find out what that allergy is. Is it diarrhea or hives or rash, or is it this anaphylaxis stuff? So when somebody is allergic, they say, oh, I'm allergic to that. Well, what does it do to you? What happens when you take it? We need to ascertain what exactly that medication does to them. Okay. Dosage and administration. So there's standard doses for specific medication. We'll talk a little bit about how they're supplied, treatment to preserve effectiveness, routes. Okay. And we'll talk about those standard doses, not today, but in other classes when we get into the specific categories or classifications. Okay, routes, how do we administer them? So how do I get a medication into the body? Well, there are lots of different ways. There's something called the oral or the enteral route. You guys ever seen the word enteral? They often will use this. Enteral just means by the normal way, by the route. It literally means through the gastrointestinal tract, enteral. So there's something called a first pass effect, and this is a blue light special. This first pass effect is specific to medications that are given orally. So if I take a medication by mouth, something rather interesting happens, and we'll quiz your anatomy and physiology here. When I eat something, and it would say it's a substance, it can be any substance right now, and it gets into my gastrointestinal tract, where is the first organ that it goes to, obviously besides the intestines? Where does all the circulation of our intestines ultimately end up in? The venous circulation. I'll give you a hint. It's part of the portal circulation. The liver. There you go. The liver. So when I take a medication orally, the first place that medication, the first organ that medication is going to go to is the liver. What do we know about the liver? Okay. It's what's called the metabolic powerhouse of the body. And most of our metabolism occurs there. Mm-hmm. And metabolism is two things, right? It's not always breaking things down. It's making things, building things up. There are two types of metabolism. There's anabolism, and that's making stuff. and there's catabolism, breaking stuff down. So both of those things can happen in the liver. And what can happen is, after being absorbed, that medication will go directly to the liver, and it will undergo metabolic changes immediately once it gets to the liver. And that is known as the first pass effect. That medication's first pass is through the liver. But what happens if I give a medication maybe in the IV through a vein, or I have somebody inhale that medication? Is it going to go to the liver right away? No. So they will not have a first pass effect if I give the medication by a different route other than oral. So does that kind of make sense? That if I give it oral, the first organ, proper organ that medication will go through is through the liver. So you're going to have metabolism occurring very quickly with that medication versus one given in the IV. And we'll talk about what can happen. Ultimately can result in needing to give higher doses of certain medications if you're going to give them orally, like certain antibiotics. If they're going to be taking them orally, we may have to give much larger doses than we would give maybe in the IV, for example, because of this first pass effect. Okay, enteral routes. So enteral is just the gastrointestinal tract. Oral, sublingual. What do I mean by sublingual? Where is that? Underneath the tongue. Okay. Sublingual routes are generally absorbed very quickly because your tongue is very vascular. Nasogastric tube. What's a nasogastric tube? There you go. You insert through the nose, sometimes through the mouth too, goes into the stomach. And then rectal, or sometimes PR, you'll see, per rectum. For patients that may be ordered something called NPO, and that means nothing by mouth, or nothing per os. PO is oral, SL is sublingual, NG is nasogastric, PR is rectal. Okay, and then we also have something called parenteral. So enteral is through the typical means. Parenteral is not through the typical means. It's a para, and of course para meaning not quite or alongside or complementary to the enteral route. So these are medications given generally that'll go directly into the bloodstream. The major parenteral routes that we find are IV, intramuscular or sometimes IM, or subcutaneous, sometimes SC. You also have intra-arterial and central lines. These are special catheters that we'll talk about later on, not right now. But you give them pretty much directly into the bloodstream. Now, an intramuscular or subcutaneous medication will take a little bit of time to be absorbed into the bloodstream, but we're still not giving it by mouth, so they call it parenteral. Okay, what did I say pharmacokinetics was? It's a movement of a medication, and it's what? What the body does to a drug. All right. So let's just talk about pharmacokinetics. It's a mathematical basis to basically assess the time course of medications and their effect on the body. Guess what? We have very little math. So you guys don't have to worry about a lot of the math here. Helps determine the amount, duration, and frequency in what kind of a dose we need to give. These, and this is a blue light special, these are the 4 processes that will occur with pharmacokinetics: absorption, distribution, metabolism, and elimination. And we'll talk about them in a little more detail. Or ADME, if mnemonics help you guys out. So I just put a little point down here. Pharmacokinetics is a movement of medication. It can be seen as what the body does to a medication. And then dynamics is what the medication does to the body. Okay, so the first thing that has to happen is we have to absorb this medication. It has to be absorbed into the body. Well, prior to absorption, we might have to do a couple of things to it. If I take something orally, for example, do I have to actually disintegrate the medication? Yeah. If let's say I take a Tylenol or an ibuprofen for my back pain, that capsule has to be disintegrated before it can be dissolved into the bloodstream. Would you guys kind of agree with me there? Mm-hmm. But let's say that a medication has already been disintegrated. Say it's dissolved in an IV solution and I give it into the IV. Do I even have to worry about disintegration? No. Nope. Goes straight in. So there's another thing when we talk about certain medications and absorption. How does it get into the body? If it needs to be disintegrated, it's going to take a lot longer to get in. And if it's already disintegrated or dissolved in something and it's given into an IV or something like that, it'll be much quicker. So a drug that's already in solution does not have to be disintegrated. It'll work much faster. Routes of absorption, we talked about these already: oral or invasive or parenteral, IV, intravenous, IM, intramuscular, SC, subcutaneous. Inhalation, that's going to be really big for us. And then absorption, certain things we can absorb right through our skin. Okay, we talked about IM, okay. IV injections completely bypass the absorption process because IV medications are already disintegrated, right? I give them, they go directly into the venous system, and I don't even have to worry about absorption. However, if they're given orally, absorption is the first rate-limiting process. And what I mean by rate-limiting is it takes some time to absorb because it needs to be disintegrated. Okay, there's also something called the bolus. And what a bolus is, and you'll talk about it a little later on in the program, is if I give an IV medication very rapidly, I bolus it in, do I have a very rapid onset of effect? Yes, the effects happen very rapidly, but can the effects then go away very rapidly? Sometimes they can go away very rapidly. So there's also something called an IV drip or an infusion where I give a steady drip of a medication into the body. And does that effect go away very quickly? No, because I keep what's known as a steady state or concentration of the medication in the body. So continuous infusion gives a regulated constant dose of medication over time, and it's considered the steady state. Some medications are designed where I have to give them a bolus to get that effect really quick, and then often I'll start a drip after I give the bolus to keep the steady state going. Because if I give it really quick, yes, their onset will happen very quick, but then because it was given very quickly and it's being metabolized and eliminated very quickly, what you'll see is you'll see it onset real quick and then offset will happen very quickly. So what you want to do is you get good onset and then start your drip to continue the steady state of the medication. Not really going to talk about that kind of stuff in this semester. Therapeutic range, it's just a range of a drug concentration in which the drug produces a response. So what I mean by this is I need to have a certain concentration of a medication in the body to act, to have some sort of response. And let's say that I need 50 milligrams per deciliter. Deciliter is 100 milliliters. So I need 50 milligrams in every 100 milliliters of my blood for a medication to have an action. And let's say that I look at the blood and it's 10 milligrams per deciliter. Am I going to have good action of that medication if this is a concentration of it in my blood? Because this is what we want, right? This is a therapeutic range. Generally, it's between like 50. It'll be 50 to 60. There'll be a little range there. If I measure it in the concentration of my patients at 10, are they going to have a good action? No. Let's say it's 100. Is that okay? Well, it's above 50 to 60, right? We're okay. What do you guys think? It's too high. And if it goes above the therapeutic range, we have toxicity. If it goes below the therapeutic range, we don't have good effectiveness. Does that kind of make sense what they mean by therapeutic range? Now, there's also something called bioavailability, and that's the amount of a medication that's actually absorbed. And this is a blue light special, by the way. So let's say that I give somebody 100 milligrams of a medication. Okay? But the medication's bioavailability is 80%. Everybody's okay? You guys are following me so far? So I give 100 milligrams of medication, but the bioavailability of that medication is only 80%. So how many milligrams will actually get absorbed? 80 milligrams. Because 80% of 100 is 80, right? Everybody's okay there? You guys are following me? So bioavailability plays a big role that, yeah, I may give so many milligrams of a certain medication, but only so many milligrams of that will make it to the bloodstream. And what makes it to the bloodstream is called bioavailability. Some medications have very high bioavailability. Some medications have very low bioavailability. High bioavailability medications, we may not have to give a whole lot of. If the bioavailability is low, we may have to give a lot more of it. Okay, it's influenced by how soluble the drug is. Does it dissolve? The form, is it oral or IV? How do I give it? Am I inhaling it or am I swallowing it? Which one, if I say I swallow a pill or I inhale a medication, which one do you think is going to, its onset will be faster? Inhaling, right, yeah, inhaling, because I'll have good absorption right there at the lungs versus swallow will have to be disintegrated, and then it'll have to go to the liver and go through first pass. Okay, the pH and the different salt forms of it. Okay, right, unless given by IV, I'm not really going to talk, you're not going to be tested real heavily on cell barriers. Just know that if I give something IV, is it still going to have to cross a cell membrane somewhere? What do you guys think? Yeah, because it's going to have to get out of the blood, right?
Yeah.
If I give something in the blood, and let's say it's for an infection that's in my foot, that medication is going to have to it's going to have to move through different cell membranes to get to the infected tissue in my foot. Cell membranes, as you guys know, are primarily composed of what? Lipids or fats. There's a fatty layer in the middle, and then they have a phosphorus layer on the outside, on the inside, and they call that a phospholipid layer. And we know that can polar molecules get through the lipid layer, or charged? Can charged substances get through the lipid layer of the cell membrane? No, they cannot. Because lipids are non-polar, right? Lipids are non-polar. Charged substances are polar. So a lot of your like chloride and sodium and magnesium and calcium, all these things that take on a charge in the body are not going to easily get through the cell membrane. So certain medications that have, let's say they're highly polar when they're dissolved, are going to have more difficulty, more trouble getting through cell membranes than non-polar medications. But you're not going to be tested real heavily on that. But that's just to kind of give you a little more insight. Cell membranes, how do drugs get through cell membranes? Okay, let's break this down here. What is diffusion?
Higher concentration to lower concentration.
What's moving from higher to lower concentration?
The solution.
The solution, or?
No.
So if I have a solution, draw a cup here, and I'm going to draw two cups. And if you can imagine, this is a membrane between the two, okay? And I have a lot of dissolved stuff in here, and I don't have a whole lot of dissolved stuff in here. Okay. So the solution itself, the stuff that's dissolved in here, these little particles, what do we call those? Solute. And then whatever they're dissolved in, well, just to pretend that there's water, we call that water what? Solvent. Okay? So solute is dissolved in solvent. Is diffusion talking about the movement of the solvent or the movement of the solute? Okay, diffusion is the movement of the solute. And where does the solute want to go?
To lower concentration.
Okay, so the solute is going to want to move this way. Everybody's okay there. It's going to move from the higher concentration to lower, and it's going to want to try to get through the cell membrane. That's what diffusion is. That's all diffusion is. Facilitated diffusion is just I have a channel on a cell that helps it move through. It's still diffusion. Active transport, that would be if I wanted to move, let's say this little guy here, I wanted to move him here. Am I going against the gradient? Yes. So do I have to use energy? Yes. That's active transport. Ion channels are just that. They're protein channels that help ions move in and out of the cell. And pinocytosis is just a cell literally engulfing something and swallowing it. Okay. Yep. You're not really going to have to worry about all that too much. Don't worry. Ionized versus unionized. What did I say about charged particles? Do they get through cell membranes easily? No, they do not. What does ionized mean? It's charged. There you go. So if something's ionized, it's charged. That's all this is saying. That certain medications become ionized at certain pHs, and some are acids, some are bases. That's all you need to know right now. So don't worry, I'm not going to be testing you. I'm not going to say, hey, this medication has an ionization pH of 7.6, and it's in this kind of environment. What's it going to do? You're not going to have to answer that kind of question, so don't worry. Okay, unionized form. Unionized is non-charged, right? And it can get through lipid membranes easier. An ionized or charged form will have a more difficult time getting through. This stuff here, just cross it out. You don't have to worry about the pKa and all that. You had that in chemistry, I'm sure. Okay, facilitated passive diffusion, talked about that. You can put an X through that if you want and just write the channel. There's a protein channel that helps it get through. It's still diffusion. Active transport, if we want to make this a little easier to understand, just write, or even draw this picture up here, and just go, I'm transporting something against a gradient, and I have to use energy to transport it. That's active transport. Okay, ion channels. What's the big ion channel that we run into in medicine? What's the big one? Sodium, potassium pump. There you guys go. Sodium, potassium pump. That's the big one we worry about. Phagocytosis, we talked about that. The cell literally engulfs and eats whatever it wants. Okay, so that's absorption. Distribution, so once I get a medication to absorb, we'll have distribution. Remember, we're talking about pharmacokinetics here still. Distribution, so after it enters the systemic circulation or the circulatory system, I need to get it to the tissues. I need to distribute it. What do you think the primary vehicle or the primary method of distribution is in the body? What do you guys think? There you go. Yeah, blood. Blood is the look, there you go. Yeah, a little cheat there. just testing you guys here. All right, yeah, that's how I primarily get medications to move around. Okay. Yes, sir.
This is first use, right?
Yeah. So it's dependent on a lot of things. Do I have good blood flow? If I have very poor blood flow, am I going to have good distribution? What do you guys think? No, not at all. Fat or water soluble? If something dissolves in water, if it's charged, am I going to have good distribution? What do you guys think? What's blood made of? Plasma. What's that made of mostly? Mostly what? Water, right? So if something is charged, it dissolves in water, right? That's what, because water is a polar molecule. It's charged, it dissolves in water. It's going to be distributed really easily. If it is lipid soluble, it may not be distributed as easily. Does that make a little sense there? Okay. All right. There's some words. Volume of distribution, or the VD. That's just an area where the medication likes to go. Certain medications like to go to fatty areas. Certain medications like to go to watery areas. Fat soluble or lipophilic get through fats easier, or through cell membranes. Lipophilic drugs have increased efficacy. That just means it works better, sometimes too much better, in patients that have more fats. Hydrophilic, they don't like water, have increased effect in patients with lots of water. Okay, metabolism. So we're on to step 3 now. So we had absorption, we have distributed the drug, and now what do we need to do? We need to metabolize it. Where does most of the metabolism of medication occur in the body? The liver. And there is an enzyme system known as it's called a microsomal drug oxidation system, or the cytochrome P450 oxidase. That's a big word, isn't it? P450. Just remember that, P450. And it's a bunch of enzymes that do lots of metabolism. If a medication undergoes lots of metabolism, it'll generally be in the liver. Does that mean I'm getting rid of it, a medication, if I'm metabolizing? I'm getting rid of it? No, what am I doing? I'm either breaking it down into something, or I'm building it up into something. So certain medications, when I give them, they don't have any action whatsoever until they go to the liver and they're turned into their active form. And that's called an active metabolite. Some medications, they're in their active form right away and they become deactivated when they are metabolized. It all depends on what the medication is. Before we can get rid of a medication, though, we're going to have to metabolize it generally. You generally don't excrete medications in the original form that they enter our body. The broken down drug is broken down into what are called metabolites, and hopefully we can excrete those metabolites. And these are the ways that we get rid of stuff. Generally through the urine, feces, sweat, and the lungs, believe it or not, we can have some elimination. But just remember, metabolism is not elimination. It's different. Okay, drugs can be metabolized all kinds of different ways we can do it. Oxidation, reduction, hydrolysis, conjugation, condensation, isomerization. Oh my gosh, that's too much to remember. Guess what? Don't worry about memorizing all this. The big thing that you guys will run into at this level is something called the redox reaction. And you guys remember that from chemistry? It's an oxidation or reduction. And we'll make it really easy. I'm not going to test you guys on this anyway, but we'll make it really easy anyway. If I oxidize something, I'm either adding oxygen or I'm taking electrons away. If you got that, you got oxidation. Reduction is adding hydrogen or adding electrons. That's it. That's oxidation reduction or a redox reaction. And when you guys go to compete in the sputum bowl here in a little bit, when you go to Albuquerque later on program and you compete in the sputum bowl and they have a physics and pathophysiology question that comes up, boom, you got it. You got it. I like to say that our team won because I knew what oxidation reduction was, but we didn't win. I knew what it was, but we didn't win anyway. Almost one stage. All right. So there are two types of metabolism. Anabolism is making, catabolism is breaking down. Okay? That's really all we need to know right now. When a new substance is created from the metabolism of medication, it's called a metabolite. Some metabolites are active, and we call them active metabolites. Some metabolites are not active until they're transformed into their active metabolite. An example of that would be codeine. You guys familiar with a painkiller called codeine? Codeine is not active. When I give somebody codeine, I swallow it, or what's called methylmorphine, it's not active. It has to go to the liver, and it has to be turned into its active form through metabolism before it has action. And lots of medications work that way. Most of the medications we give don't work that way. They are active when we inhale them, and there isn't a whole lot of metabolism that needs to occur. Okay, metabolism rates vary quite a bit among patients. Some people rapidly metabolize, some people don't so much. Lots of factors. Liver disease is the biggest factor that we need to worry about. If somebody has liver disease, are they going to be able to metabolize effectively? No. So certain medications will not be active in these patients, and certain medications will be too active. They can actually overdose because they cannot metabolize them and get them ready for elimination. And elimination. Elimination is getting rid of it. So hepatic metabolism generally makes drugs easier to get rid of. Don't worry about this. Renal excretion rate is affected by how well the kidneys are working. That's what those three things mean. How well are the kidneys working? If you guys got that, you're good to go. I'm not going to ask you a glomerular filtration rate question on the exam. How well are my kidneys working? Okay, impaired renal function can lead to lots of prolonged effects. I'm not going to have good elimination of these medications. Most of the elimination will occur by the renal system in the body. We do have some elimination through stool or feces, through the lungs, through the sweat. What drug do we see here in New Mexico? And it actually can be eliminated through the lungs. We see it everywhere. It's a big problem. Alcohol. There you go. Alcohol or ethanol can be eliminated through the lungs. How do we know? Because we do breathalyzers, and lo and behold, you have alcohol in its native original form. Most of alcohol elimination occurs through the kidneys, however, but there is some that can be eliminated through the lungs. Okay, so that is pharmacokinetics. That was pharmacokinetics. Absorption. What's the next step? Distribution, metabolism, and elimination. You got it. Pharmacodynamics, that's just what the drug does to the body. Okay? Selectivity refers to the extent of which a medication acts on a site. And we'll talk about these sites. Generally, a medication will bind to what's called a receptor. And I'm going to talk about these receptors in a little more detail when we get further on. There's actually something called the TM7 or transmembrane 7 receptor. And you will know these as the beta and alpha receptors that you studied in anatomy and physiology. And we'll study those in a little more detail here in about 4 weeks. Basically, a drug can bind to a receptor. What is a receptor? A receptor is a protein, right? And what's interesting about proteins? They have a very special shape, right? Called a conformation. And generally you have actually 4 levels of complexity in a protein. You have your primary structure, which are your amino acids coming together. And then you have your secondary tertiary structures, which generally is going to be a beta sheet or an alpha helix, and that's hydrogen bonding, bending it. And then you have a quaternary structure, and that's where we put all these together. And an example of a quaternary structure would be like hemoglobin. Now, do you guys have to know all that stuff for here? No, you don't. You just have to know that ion channels are generally proteins, and that proteins have a special shape called a conformation. And if you change that shape, the protein will do something different. It'll work differently. And there's something called the lock and key. So let's say that I have my cell here, and I have a receptor, and I have a medication, and it binds to this receptor, and it changes its shape or its conformation. We'll say that it maybe opens up like that. And that change in shape or conformation then causes something else to change, and that causes something else to change, and that causes something else to change, and I have an action occur. That is what happens with most medications, is to give the medication, it binds to a receptor, the receptor changes shape, kind of like a lock and key, like I put the key in the door, I turn the key, and the lock opens up, and the door opens. Very similar thing occurs here. Lock and key theory. If you understand this, you understand all of this here. Everybody's okay? So I do not want you guys to get too worried about the big terminology. Okay, racemic mixtures. Racemic mixtures. If you guys remember from chemistry, there's something called an enantiomer or an isomer. And what is that? What is an isomer or an enantiomer? So I have a molecule that's shaped like this. Okay. Can I also have another form of that same molecule with just a slightly different shape? Same number of atoms, just a slightly different shape? All right. So I have a left-hand or right-hand form of a molecule. It's called the D. The left-hand form, which is called the L. And certain medications have a D in an L or D in an L form. And when I have a medication that has a 1-to-1 mixture of D and L molecules, we call that racemic. And there's a medication that we give in respiratory therapy called racemic epinephrine. And it is a mixture of a 50% or a 1-to-1 mixture of the left-hand version of epinephrine and the right-hand version, or what we call the D and L enantiomers of that. Now, sometimes the left-hand version can have different effects than the right-hand version. And we'll talk about how that's important when we talk about things like albuterol and a medication called Zopanex or levoalbuterol. But as long as you guys realize that you can have different versions, a left or what we call left and a right-hand form of a medication, you guys will be okay. And when I have a 1-to-1 mixture, and this is a blue light special, 1-to-1 mixture of this left and right hand enantiomers, we call that a racemic mixture. And racemic epinephrine is just one such mixture. Okay, antagonists. So if I give an antagonist, a medication that antagonizes So here I have a cell, I have the receptor, a cell, and the receptor. If I give an antagonist, it will attach, and it will antagonize. It will prevent something from happening. If I give an agonist, on top here, an agonist binds and causes something to happen. So certain medications antagonize actions, certain medications agonize. Agonize is to make something happen, antagonize is to prevent something from happening. Potency is just the amount that we need to give to produce a certain effect. Efficacy refers to the maximum effect of a medication. That's all that efficacy means. And potency. All right. Tolerance. Sometimes, if somebody gets a medication all the time and they're taking it every day, several times a day even, can their receptors become tolerant? Yes, and we call that downregulation. And all these things here, all these big words just means that my receptors don't respond to that medication like they used to. They become tolerant. So sometimes I have to give more of a medication to get the same effect because the receptors, they get used to it. They just get used to that medication being around. Yes, they do all these changes, but as long as you guys understand that receptors can get used to it, we'll be all right. Desensitization is just kind of a form of tolerance. It is the decreased response to further stimulation. I'm not going to ask you to compare and contrast tolerance with desensitization because they're pretty much the same thing. They happen together. So don't get too wrapped up around trying to differentiate the terminology. Drug dependence is basically leads to addiction, which results in physical or psychological need for a certain medication. And you can get dependent on medication, ultimately that can lead to addiction. Okay, pharmacodynamics. You guys remember the half-life from chemistry? And this is a blue light special. There's something called a half-life. And what it refers to is it's how long is a medication going to hang around in my body. So let's just say that I were to ask you a problem, and I'm going to say that the T1/2, that's just the abbreviation for half-life, I'm going to say the half-life of a certain medication is 10 hours. You guys good with that so far? And I'm going to give, let's say, 10 milligrams of a medication. And let's just assume that it has 100% bioavailability. And that means I'm going to give 10 milligrams, and 10 milligrams is going to get absorbed. We know that's not the case, but let's just pretend that is. So what I want to know is how much of this 10 milligrams is going to remain in the body after 10 hours? How many milligrams will remain after 10 hours?
Should be 5.
You guys good with 5?
Yeah.
So after 10 hours, a 10 with a little circle, a degree above it, just equals hour. 10 hours, I'm going to have 5 milligrams. What's going to happen after 20 hours? What do you guys think? How many of you think 2.5 milligrams? How many of you think 0? Okay, good. Then you understand how half-life works. Half-life is a half of a half of a half of a half. It's not a half and a whole. So after 20 hours, I'll have 2.5 milligrams remaining. What about 30 hours? 1.25 milligrams, and so on and so forth. Everybody's okay there? Okay, that's just the trickiness of the half-life there, is it's not half and then 0. It's half of the half of the half of the half. Okay, we know liver disease can increase the half-life of some drugs because we can't metabolize them. They're going to hang around a lot longer. Okay. Maintenance dose, we talked about that, the steady state, and the loading dose is like the bolus that we talked about earlier. Okay, toxicology and the therapeutic index. The TI, the therapeutic index, is a ratio between the minimum effective dose and the maximum tolerated dose. So, let's just try to make some sense of this. Let's say that I have a medication that has a TI of 1 milligram, between 1 milligram and 100 milligrams. So the ratio would be 1 over 100. Would you guys agree? Is that a pretty big ratio? What do you guys think? Between 1 and 100 milligrams? Well, let me give you let's do another example. Let's compare. Let's say that I have another medication with a therapeutic index of 1 milligram to 2 milligrams. Okay. So who has the smaller therapeutic index? This one here? Or this one here? What do you guys think? So this is basically a 1-to-1. So which medication do you think is going to have the higher potential for toxicology or for overdose? This one here? Or this one here? The one on the bottom, right? Because I only need to give 2 milligrams and I can potentially have overdose or toxicology occurring, whereas this one I have a big wide range. Okay? So as the therapeutic index nears 1, right down here, the chance for potentially adverse problems occurring is going to be a lot higher. Down here, my therapeutic index is 1 over 100. I have a lot more wiggle room with this medication here versus that. That's all therapeutic index is. Prescription orders, blue light special down here. So when we are looking at charts and we're looking at giving a medication, there are what we call the medication rights, and these have to happen before we can give something. We have to have the right medication. We have to have the right time to give that medication. We have to have the right dose ordered. We have to have the right route ordered, the right concentration of medication, and we have to give it to the right patient. And these are what we call the rights of medication administration. Do medication errors happen? Yeah. Yes. They are exceptionally common, guys. Medication errors are exceptionally common. We kill a lot of patients because of medication errors. A lot of patients, nurses particularly, kill a lot of patients due to medication errors. Generally what it is it's a communication breakdown. What can happen in respiratory therapy is you get called to the OR. Stats, there's a patient not doing well in the OR. You run to the OR, and you run through the door, and they say, give albuterol. And you go to the Pyxis, and you are so used to giving something called a duoneb, which is albuterol mixed with something else. You pull out a duoneb because that's what everybody gets at the hospital. But this doctor wanted albuterol, and you give the new duoneb. An error. It's that simple. It's that easy. So when we look at giving medications, certainly next semester, when we're not going to be overloading you guys a whole lot with patients, just slow down, look at the chart, make sure that the rights are good, make sure that you have the right patient, make sure that these 6 things are a go, that you have a thumbs up for them before you give that medication. Take the time and develop those good habits now. And obviously, you're going to want a physician signature and all that, but really, we need to have these rights in place. And guess what, guys? That's it for now. Okay.